morning. I am Jackie and I am your student nurse for today. I'll be doing a physical assessment with you from head to toe. Will that be okay with you?
Yes, sure.
So now, before you start the physical examination, you should first make sure that you are assessing the right patient. So I have here the patient's chart which contains most of his personal information. Now, please say your first and last name for me, please.
Miguel Adrian Hilos.
Okay, and your date of birth?
October 23, 2001.
Okay, so can you tell me where you are at?
I am at hospital.
Great, and can you tell me what we are doing here?
I am here for a head-to-toe physical examination.
Great, so can you tell me who's the President of the Philippines?
President Rodrigo Roa Duterte.
Okay, so he answered all of the questions correctly. That just means that he's alert and oriented, and that would be class 4. So now in assessing, we should follow the sequence of how you should assess a patient. Inspect, palpate, percuss, and auscultate. Except when you are assessing the abdomen, it will become IAPP, which stands for inspect, auscultate, percuss, and palpate. And the reason behind that will be mentioned later. Okay, so before we start the assessment, we are going to collect first his vital signs, which is his temperature, heart rate, respiratory rate, and blood pressure. So his temperature reads 36.5 degrees Celsius. Now we are going to take his pulse rate. Then his respiratory rate. And now we're going to check his blood pressure. So everything's within normal range, and now we're good to go. So we're first gonna inspect the head, and we're looking at the skin color if it's nice and pink. We're also going to make sure that the head is the same size as how it should be for the body, and it is. And we're looking for any abnormal movements or twitching of the face that he can't control, that are involuntary, and we don't see anything. And we're going to make sure that the face is symmetrical. Also, are the eyes and the ears in the same level? Now we're going to test cranial nerve 7 or the facial expression. So can you close your eyes tightly for me and open them up? Okay, now smile for me, frown, and pop out your cheeks. Okay, and he does that with ease. Next is we're gonna palpate the head or the cranium. We're gonna check for masses, indentations, skin breakdown, and infestations. What we're doing is we're feeling any masses, indentations, and skin breakdown. Also, look inside the hair and make sure that there are no infestations like lysis and any areas of baldness which indicates alopecia. Now remove the gloves and perform hand hygiene. Next is to find the temporal artery and palpate it bilaterally. So his are about 2 plus. Now while we are here, we must also assess the cranial nerve 5, which is the trigeminal nerve. So what I'm gonna let you do is to clench your teeth, like bite down for me, and I'm going to feel the masseter muscle and the temporal muscle. Now let me test that nerve also by letting him try to open his mouth against my resistance. So try to do that for me. Okay, he can do that. Now we're going to feel the temporal mandibular joint, and I'm gonna have you open and close your mouth. And I'm feeling for any grating or clicking sensation, and I feel none. Then we're gonna palpate also the sinuses. So I'm going to put pressure on your sinuses and tell me if you feel any pain, okay? So the maxillary?
No.
And the frontal?
No.
Okay, that's great. Inspect the eye. We're looking at the eyelid, the sclera, the iris, the pupil, and the conjunctiva, and you shouldn't see any swelling or anything like that. Next is we're going to be looking for any involuntary shaking of the eye called nystagmus, and to do that we're going to take our pen light and move it to 6 different directions, and the patient will follow the pen light as to where it moves by using his eyes only. So let's start. Next is we're going to see how reactive the pupils are to light, and to do that we're going to have the patient stare off at a distance and shine our pen light on the inside and look if the pupils dilate. But because my pen light is too bright and it wouldn't be appropriate for the eyes, I'm just going to show you a short clip right here about how you should do it. Next, we're gonna have him stare off at a distant object that helps dilate the pupils, and we're going to take a pen light and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict. Next, we're going to move on to the ears. So first, what we do is we inspect the ears. We look on the outside of the ear. Is there any abnormalities, any redness, any drainage, and anything like that? And if the patient is feeling any pain, next, we're going to palpate on the ear. We're just going to move it around and tell me if you have any tenderness whenever I do that, and any abnormal masses or lesions, and then move the targets a little bit. Does it hurt or anything like that? So now while you're there, you can use the otoscope to inspect the tympanic membrane, and remember that the tympanic membrane should be a pearly gray translucent color and should be shining. Next is to test the vestibulocochlear nerve. So what I'm going to do is I'm going to close one of his ears and then whisper 2 words on the other side, and he needs to tell me what I said. So you ready?
Ina.
Next, we're going to move on to the nose, and we're going to inspect the nose. We're going to make sure that it's midline on the face, which it is. Are you having any trouble with your nose? Are you having any drainage or anything like that? Okay, so no. And you want them to check the patency of the nose. I'm gonna have you close one side of the nostril, breathe out the other, and vice versa. Okay, I heard airflow is nice. Then you want to take your pen light and you just want to look inside the nose, look for any drainage, redness, and everything looks so clear, I don't see anything. Then we're going to test the olfactory nerve, the sense of smell. So what I'm going to have you do is I'm going to have you close your eyes and I'm going to put something in front of your nose and have you breathe in and smell, and you tell me what you smell. Okay, so whenever you do this, use something that is pleasant smelling.
Cold.
Then we're inspecting the lips, make sure they're nice and pink in color. Then test the hypoglossal nerve and let the patient stick out their tongue and move it from side to side. Okay, and he does that with ease. Then I'm going to inspect the inside of the mouth. Look at the inside of the cheeks if it's nice and pink. Do you see any lesions or anything like that? Look at the tongue. It should be moist and pink. Look also for the gums and look around for cavities or any broken teeth. And you're gonna look at the soft and hard palate. Then I'm gonna have you say ah, and what you want is that uvula to move up. Then we're going to the neck. So first, you're gonna have the patient extend the neck up a little bit and you're looking at the trachea. Is it midline? Look for any lesions and look for any lumps like what you might see in patients with goiter or hyperthyroidism. And I'm gonna have you move your head up and down and side to side. And then I'm gonna have you try to shrug against my resistance. So shrug. And he does that with ease. We're gonna place him at a 45-degree angle and we're looking for any jugular vein distension. And we're also going to palpate the trachea just to confirm it is midline. Then next, we're going to palpate the lymph nodes, all sides of those. And as I do this, tell me if you feel any tenderness. So we're gonna start at the preauricular, then the postauricular, then the parotid jugular digastric, the submandibular, and the submental. Then the superficial cervical. Then down to the deep cervical chain. And then the posterior cervical, and right above the clavicle. And the supraclavicular. And I did not feel anything and no tenderness. Next, we're gonna palpate the carotid artery, and this is one artery that you do not palpate bilaterally. You do one individually. And his is nice and bounding. It's 2+. Then we're just going to feel on the other side. And same strength, 2+. Then lastly, what we want to do is we're going to auscultate the carotid artery. And you're going to do one side at a time. And you're going to compare sides and you're going to listen with the bell of your stethoscope. And we're listening for a swishing sound. So what I want to do is I'm going to have you breathe in and breathe out and hold it for me, okay? Go, breathe in, breathe out. Now did I hear on that side? Okay, breathe in, breathe out for me and hold it, okay? And I did not hear any on that side as well. Now let's move on to the upper extremity. So first we're gonna palpate our pulse or the radial artery. So feel those bilaterally, and they are 2+, they're equal. And then we're gonna check for the capillary refill, and to do that, we're just gonna press down on the nail bed and see how fast it comes back. It should come back in less than 2 seconds. Then we're gonna check for skin turgor. Just pinch on the skin and see how fast it goes back. And that was good. Then we're just gonna look at the range of the motion of the fingers and the hands. Look at these joints in the hands and ask the patient, are you having any pain in your hands or anything like that? Great, no. Then you can palpate the brachial artery, which is found in the bends of the arm. And just a side note, if this was a patient that was getting dialysis and they had an AV fistula, you would want to palpate that and feel for the thrill. Make sure that it is present up in that arm wherever their fistula is at. Then, okay, it's 2+. Then test for the muscle strength. So what we're gonna do is I'm gonna have you squeeze my fingers as hard as you can. Okay, that's really good. Then I'm gonna have you push up against my hands and I'm gonna push up against your arms. Okay, push. Okay, very good. Okay, and 5+, normal strength. Then put your hand underneath the elbow and just feel as you move the arm. Do you feel any grating crepitus of those joints? Another thing you want to do with the upper extremities is to check for a drift. And what you will do is you'll have the patient hold out your arms and close their eyes, hold it up for about 10 seconds, and you're looking for a drift like this. So go ahead, do that and close your eyes. Okay, we're assessing to see if this hand will drift upward. Next, we're moving on to the chest, and we're going to inspect the chest. We're looking for any abnormalities like lesions or any wounds, masses, pain, redness, and swelling, and anything like that. We're also inspecting the patient's effort of breathing. Is it really labored? Are they using those accessory muscles to breathe? Also, we're looking at the interior and posterior diameter of the chest. So, you're looking for that barrel chest, which can be found in patients with like COPD. And now what we're going to do is we're going to listen to heart sounds. So first, let's auscultate heart sounds, and we're going to do this in 5 locations, and they are based on where the valves are located. And I like to remember the mnemonic, all people enjoy Time magazine, and the first letter of each word represents the valve. So A would be aortic, P would be pulmonic, E would be Erb's point, T is for tricuspid, and then M for mitral. So again, using the diaphragm, we're gonna listen at the right of the sternal border at the second intercostal space, and that's going to be the aortic valve. So to find that second intercostal space, find the sternal notch, go down to the angle of Louis, and then just go a little bit to the right, and you're in the second intercostal space, and this will be the aortic. And we're just going to listen for the aortic valve. Okay, breathe in, breathe out. Then we're just going to go a little bit over to where the pulmonic valve is, and it is found on the left of the sternal border at the second intercostal space, just right across on this location. Then we're going to go a little bit down to the third intercostal space, and this is the Erb's point. Then we're going to go down to the fourth intercostal space, and this is where the tricuspid valve is. Then going to go to the fifth intercostal space, we're going to listen to the mitral valve. And there's something special about this site. This is the point of maximal impulse. This is where you're going to listen for the apical pulse. So we're gonna sat here, and we're gonna count it for 1 full minute. And a normal apical pulse an adult should be is 60 to 100 beats per minute. And his apical pulse was 68. Then we're going to switch over with the bell of our stethoscope, and we're just going to repeat on those locations, and we are specifically listening to heart murmurs, so that's swishing, blowing sounds. and I did not hear anything. Now let's listen to long sounds. Now when you're listening to long sounds, you're listening for abnormal sounds. First, we're going to listen anteriorly, and what we're going to do is we're going to listen with the diaphragm of our stethoscope. And we're going to start at the apex of the lungs, and we're going to always compare sides. And just enter way downward and assess all the lobes of the right and left lung. So first, let's start up here. So we go to the apex. We're gonna compare sides. Then we're gonna move down to the second intercostal space, and this is going to help us assess the right upper lobe and the upper lobe. So another deep breath in and out. Then we're going to go down to the fourth intercostal space, and we are going to assess where our right middle lobe is and our left upper lobe. Because remember, the right lung has 3 lobes and the left lung has 2 lobes. Then we're just going to go down a little bit. Then we're gonna go mid-axillary at the 6th intercostal space, and we're gonna listen to the right and left lower lobe. So you just want to turn to the side and the other side. Okay, now let's listen posteriorly again. Using the diaphragm, with the stethoscope, you're going to start listening at the apex. So you're going to listen in between where the scapula and the spine are. So down in these regions right here. And again, we're just going to compare sides. Okay, now we're going to assess the abdomen, and remember, we're switching our sequence and how we assess. We're going to do inspection, auscultation, and then percussion and palpation. So we're going to do auscultation after inspection because we don't want our bowel sounds to be altered due to deep and light palpation. So whenever you're looking and assessing the abdomen, have the patient lay on their back, and what we're going to do is we're going to inspect the abdomen. And first we want to ask the patient, are you having any stomach issues at all? No. Okay, when was your last bowel movement? Yesterday morning. And how are you urinating? Do you have any pain while you're peeing? Okay, so there's none. Okay, so when we're inspecting the abdomen, we're looking at the abdominal contour, and also we're going to know if there's any pulsations a lot of times in this area. Now, I can see the aortic pulsation in these patients right above the umbilicus. And also look for the belly button and check for any masses. Do we see any hernias or anything like that? Also, if your patient had any wounds, you would want to look at that. So now we're ready to listen to the bowel sounds. And what we're going to do is we're going to listen with the diaphragm of our stethoscope. We are going to divide the stomach or the abdomen into 4 quadrants, having the belly button as the midline. So we're going to start first in the right lower quadrant and work our way clockwise, and we're gonna listen all 4 quadrants. And take note that you should hear 5 to 30 sounds per minute. And if you don't hear any bowel sounds, you need to listen for 5 full minutes. And you need to note those areas that are normal, and also if those areas are hyperactive or hypoactive. Okay, so let's listen. This is our right lower quadrant, and we're gonna move out to the right upper quadrant, then move over to the left upper quadrant, and then down to the left lower quadrant, Now we're going to listen for vascular sounds, and you're gonna do this with the bell of your stethoscope, and you're gonna listen to the aorta artery, and it's a little bit below the xiphoid process, a little bit above the umbilicus. So about right here, we are listening for like a blowing, swishing sound. Okay, and none is noted. Then we're gonna listen at the right and left renal arteries, which is a little bit down from the aorta location. So here is the right. Okay, none noted. And then over the left. Then we're gonna listen at the iliac, and it's a little bit below the belly button right here, and then listen on the other side. Okay, so now we're going to do palpation. First, we're gonna do light palpation and then deep. So we're going to divide again the abdomen into 4 quadrants, having the belly button as the midline. And we are going to start at the right lower quadrant. So the patient is going to tell to me whether he feel any pain or tenderness. Okay, so we're gonna start here at our right lower quadrant, and it is right here. So we're going to do a light palpation, and we're going to work our way around, and we're just feeling for any rigidity, any lumps, any masses, and the patient will report any tenderness and anything like that. Okay, so now we're gonna do deep palpation, and we're gonna go about 4 to 5 centimeters, so a lot more deep. Then again, you are just feeling for any masses, lumps, and then tell me if you have any tenderness. And sometimes you can do this with 2 hands because one hand wouldn't be strong enough. So it's nice and soft. This is the reason why you're going to do this after percussion and after auscultation, because we don't want our bowel sounds to be altered. So now we're going to assess the lower extremities. First of all, what we're going to do is we're going to inspect. We're going to look at the color from the legs to the toes, making sure it's nice and pink. So we're looking at the hair growth as well. You want to make sure that there is normal hair growth, and here we have excellent hair growth. And also, do you see any abnormal swelling? And look at the legs and the feet for any redness and swelling. So ask the patient if he has any pain in his legs or anything like that, and make sure that there are no redness on the joints, because a lot of times with gout it likes to start out in the big toe. So make sure that everything looks good. So inspect those feet, make sure there's no ulcers or anything like that. Next, you want to palpate the pulse. We'll palpate the popliteal pulse, which are behind the knee, and those are about 2+. They're equal bilaterally. Then feel his legs if they're nice and warm. And I'm going to push over his tibia firmly, and I'm seeing if there's any edema. So push there. So now we're going to palpate on the feet, and we're going to feel on the pulses, the posterior tibial. Okay, so 2+, really good. And then we're gonna feel the dorsalis pedis, which is on the top of the foot. And if you can't ever find this, because sometimes these are hard to find in patients, you can get a Doppler if you have one on your floor. Okay, so now I'm going to have him push against my hands. So push against my hands. Okay, good job. Now I'm gonna have you raise your legs against resistance. Okay, raise your legs. Okay, good job. Now we're gonna check the Babinski reflex, and you can use your reflex hammer for this and use the end of it, or you can use your finger if you don't have that. And what we're gonna do is we're going to take this up through the ball of the foot and curve it. And we're looking for the toes to curl, in which would be a negative normal response. So let's check that. Okay, and that was normal. Okay, so next we're going to assess the back. So whenever you're looking at the back side, you're gonna look from the head all the way down at the back. And you really want to pay attention to any abnormal moles, lesions, wounds, anything like that. And assessing for skin breakdown, especially for patients who are mobile. So that would really be concentrating on in the backside area. And on the coccyx, make sure that it is normal because that's where a lot of breakdown usually happens. Also assess the patient's spinal cord and make sure it's normal because some patients may have kyphosis. So now that wraps up my head to toe assessment. So thank you for watching.